Hey, Paul.
Kind of. As always,
This
say probably a primary care physician anyway.
this was an episode that you produced, primary hyperparathyroidism, with guest Dr. Lindsey Kuo. And Paul, why don't you start us off? I mean, like where to begin with this topic?
It's worth it talking about the symptoms as an overview, Matt, just because in large part, they can actually determine whether someone not proceeds to surgery. There's a set of criteria for patients who don't have the classic symptoms, but I think that's a good place to start because I think we've all checked basic labs, then had the calcium come back borderline or elevated, and then if you've done the Williams technique, you repeated it, and then it's still borderline or elevated, then you're like, oh no, now what do I have to do with
Now I
this?
have to, yeah.
So you're forced to address it, and 9 times out of 10, it's going to be primary hyperparathyroidism. For me at least, that's far and away the most common cause of this elevated calcium. Even though sometimes it normalizes the PTH, then we'll still stubbornly stay high. So it's from there. Once you confirm that with the labs, it's probably worth asking patients about symptoms because the indications to operate are the classic symptoms, and then there's a little bit more nuance for the symptoms that are non-classic, which we'll get into and I'll ask you about. But the classic symptoms, the patients that proceed right to surgery, are the ones who have bone disease specifically. And by that, I mean things like osteoporosis or these brown tumors, which are these distinct radiographic findings, or fractures or kidney complications, which include your urinary stone disease and then also nephrocalcinosis, which I've never seen other than Google image searches, and it looks gnarly. But then there's also a whole host of other sort of non-classic symptoms that are worth asking about once you've gotten to this point in your workup. So Matt, why don't you talk us through some of the things that you're now asking for now that we know better?
Right. Some of these make sense pathophysiologically, like you can ask about polyuria, polydipsia. Sometimes people have like constipation or abdominal pain. She said heartburn is another one. But the ones that she said that like she asked about like fatigue, dysphoria, maybe some people tell her they have short-term memory loss. These are not really